hormones that have been looked at, certain anti-inflammatory drugs have been looked at in the past. Some have not panned out, some have failed. Some failed because we did not know all the details. So there are ups and downs like any other field. So you may read in the paper, oh wow, this is great, and the next day you may hear about something else that this is really bad. But some of it is just the media thing too. So I think it's good to have some time frame and patience. Things are moving on, and things are not simple. I wish they were simple, but they're not. But I can tell you, yes, things have moved a lot rapidly in the last 10 to 15 years than they had moved in probably in the last 50 years. So if there are any questions, I'll be happy to answer. There are a couple of things I want to point out, that in addition to medications, medication, I initially said, medication is just one piece of management. There are things like preventing side effects of other medications, preventing the impact of other medical illnesses like diabetes and high blood pressure. There are issues related to social environment. There are issues related to safety, economics, caregiver burden. So there are so many things, and therefore organizations such as Alzheimer's Association and other community agencies are extremely helpful, because there are many things that they do, and they do superbly that we as clinicians or physicians can do. Okay. All right, so yes, questions?
The side goes up here, second
Uh-huh.
most caregivers, I don't think it's true.
Which one? Most caregivers do not rotations when you go to the diagnosis?
Right.
Okay. So yeah, this is a debatable question, although this is based upon study. What happens is that people who come in with family members, and if you ask family members, do you want your mother, father, or husband, wife to know about their diagnosis, they will say, no, I'm afraid they will not take it well, they would become sad, or they may want to die. But if you ask them, okay, what if I were to tell you you have Alzheimer's disease in future? And they will say, I definitely want to know it. So this is based upon a study, and I'm not saying it's right or wrong. It's just that we have found, and papers have been published. And there are a few things. When caregivers are there, they want to protect. They feel like this is the end of life sometimes, or they may feel that my mother or father or husband or wife will not be able to take of it, and think that this is. Actually, I, in my practice, find that people want to know about their diagnosis, even though it does, especially in early stages, distresses them. But remarkably, they overcome it. So next time when they come in, they are ready, and they are ready to take the challenge. They are telling me, okay, what else can you do? What can I do? How is it going to happen? Not everybody is the same, but still, I see that they feel it, that they, okay, all right, I have a diagnosis now, tell me what needs to be done. On the other hand, family members may think, I'm afraid he or she will have a breakdown, or will not be able to cope with it. So, all right, questions?
He knows me. Doctor, I've been thinking about this for a long time. We're all different because we're chemically different. Chemically different. That's the main reason. And that's why some have Alzheimer's and some don't. That's part of the reason. What I'd like to know is, have any of the researchers looked into the structure of DNA for those with Alzheimer's and those who did not have it? And did they find that something was missing? Because DNA has some of the things that other people have in their DNA of different people.
Okay. Yes, good question. Yes, the question is that people are different. Some people have Alzheimer's, some don't. And we are all genetically, we have some differences. And it's an important question. And yes, that is being looked at. Some of the genes we have mapped. I showed one or two. But then there are others that genes have been isolated and that we know that they could be inherited and those people would have Alzheimer's. And then there is the other gene products that I showed, ApoE, is something that also is important in people who are older, people who do not have family history. It is helpful. But the complexity is that it is not 1 or 2 or 3 genes. And it is also that genes do not tell us the entire story. There is a small number of people who get Alzheimer's disease at a young age, who have definite family history of the same gene which is transmitted in a certain way, and we can detect that. There are certain tests available. There is a study, I think is going through National Institute of Aging, which is looking at people who have Alzheimer's disease at a very young age and who have what we call autosomal dominant transmission, where their mother-father had the same gene and they have it, or they have somebody else in the family. So genes are being looked at. The problem is that it is not simple. It is going on. The genes, we have found some of them, but we don't have the entire story at this point. Yes.
My question goes along with that. Are there studies of people in other countries with different dietary,
Dietary habits, right?
Habits, or other things that might give us leads on how to prevent this?
Yes, and I think there is a lecture here about Mediterranean diet, I think, the answer, right? Yes, there are collaborations, and AD&I that I showed you, Alzheimer's Disease Neuroimaging Initiative, is happening almost in is it in China, is it now going to start in India, is it in Australia, is it in New Zealand, and in the United States and Europe. So they are covering, many studies are now collaborating. And with the computer technology, everybody can share the information. So what's happening in US, things were not as simple as they are, relatively simple now than they were. I mean, now technology has allowed us to look at different. So they are being looked at. There are certain differences. Diet is just one factor. So I think it would be too simple to say that it's all related to diet. There are many other factors in different countries and different cultures beyond diet. Diet certainly is important, but there are so many other differences that scientists look at. And some of the challenges in making a scientific assessments are there too. So it's although the question is great, but the answer is going to be more difficult than just finding that it's all diet.
How are they deciding what foods are good for the brain?
It will be based upon certain designs of studying people. So, for example, if we can figure out one particular community in, say, Henrietta lives together and is in a certain diet and has less Alzheimer's disease compared to a community in Perrington, and that could help us to start the process. And then we look at different things, and then we look at different things and move on from there. So that's why sometimes you get an initial excitement about something, and then you find out it was just a chance. And that happens in science.
Yes, you mentioned a neuropsychologist. I know a little bit what a neurologist is and what a psychologist. What is a neuropsychologist, and do you recommend it for people with dementia?
Neuropsychologist is somebody who is trained in psychology, and they work at sort of a border between neurology and psychiatry. And they're PhD scientists, commonly. Not all of them, but commonly. I mean, some are what they call D-psych. They look at some of the memory testing, and they would look at how the brain processes information, what is the speed of that information, what kind of skills a person has had, and what is the change in them. So it's like one of the ways to map the brain. You know, we map the brain by looking at the picture, we map the brain or map the body by taking a blood test. Same way, it's a measure of what strengths and weaknesses in their thinking and the language they have. So it kind of fits with the overall picture. We don't we don't require a neuropsychologist to make a diagnosis of Alzheimer's dementia, but oftentimes it helps us to put the pieces together, especially in cases where we are somewhat hesitant, where we think that it isn't, but we want to make sure that we have looked at it in a much thorough way.
Is
So
it
we send them to a neuropsychologist.
Only for diagnosis, or can they be used for
They-
optimizing?
Yes, they will. They can help us to confirm, or not confirm, but they could help us to facilitate that what our thinking is in the right direction. Or if there are differences, or if there is depression or something, they can help with it. They can also establish where the person is at this point, so that in future, if we have to compare and see if they're getting worse or they're getting better, they can also help us. They can also help us in devising a plan for them. So if somebody has more language problem compared to something else, and they can tell us. If somebody has some problem that would tell us this person cannot make a judgment about, say, property, or this person cannot make a judgment about driving, then that also helps us by looking at everything in their skills and their abilities. So one more question, and then I'll have to stop. All right, go ahead, Si.
Good report. I've been in your research program now for about 6 years, and I take the amendment and the excellent patch. Last year when I went through, Ms. Weeds called up and said, how's he doing? He said, there hasn't been a change.
Wonderful. Good.
Here's hope.
That's excellent. Thank you. Thank you for making that comment. Do I have time for one more question? One more. Okay.
That kind of follows what the gentleman just said. Our daughter's 34, has been diagnosed with frontal dementia. Now, if she currently takes regular medication, would it be advantageous for her just to stay on the medication that she's on? Or do you think possibly getting into an alternative program would be more suited for her comfort?
I can't, I want to help you, but I can't address an individual issue. But just in general, a question about frontotemporal dementia. Currently, there is no FDA-approved treatment for frontotemporal dementia. Frontotemporal dementia, the treatments that are used are called off-label, which means that in doctors' experience, this might help, but there is no strong scientific evidence that they help. There are studies going on, I think in California, a couple of studies are going on in frontotemporal dementia. We don't have any study in this area. So if you can find a study in this region and if you want to participate, I think that would be another option to do it in front of you. You can look at the government site, or Alzheimer's Association can help you locate if there was a site in this area or in this region. That would be one option. Now, your question about whether other programs, depending on what the symptoms are and what you're looking at, if it's related to some behavioral issues or some mood changes, then yes, certainly those other treatment options will be helpful. Medication-wise, it's treated symptomatically depending on what the person has. If the person has mood changes or anxiety or agitation or anger or violence, those are sometimes treated. Sometimes we do treat with the same medications that we use for Alzheimer's disease, but like I said, the scientific evidence for treatment with those medications is not robust, something that is important to keep in mind. All right. Sorry, I can't help more than that. Thank you very much.